We back.
Yes, Mr. Chairman, you are live.
All right, thank you. Welcome back, folks. This afternoon, we are going to begin with a review on how we protect Medicaid and other programs from fraud, waste, and abuse. So, Director Johansson, would you please take it from there?
Thank you, Mr. Chairman. Members of the committee, again, Stephen Johansson with the Department of Health. I'm going to lean heavily on Jesse Springer, our interim state Medicaid agent, and introduce you to Andrew Chapin, who oversees our program integrity unit in the Division of Healthcare Financing, or Wyoming Medicaid. But before I hand it over to Jesse, just a few introductory comments per the agenda items. A few points that I won't belabor, but just reiterate from our last couple of meetings. You've asked us to go over kind of the eligibility and screening process. I'll have Jesse do a brief overview of that. And then we'll pivot to a few more specific topics. Number one, per the agenda, payment error rates and eligibility error rates. We'll give a brief description of that. And then we sent, to round everything out, we sent the committee an introductory briefing slide deck on program integrity, which when we talk about fraud, waste, and abuse in the Medicaid context, we have a unit that is dedicated solely to that. So we'll give a brief overview of what happens in that unit, the types of things that are pursued, some of the both state and federal parameters behind that. But by way of introduction, just a few reminders to the committee when it comes to Medicaid and Medicaid eligibility. As we presented in our agency overview in your first meeting in Casper, it's important to remember that having low income does not qualify you for Medicaid in Wyoming. As a non-expansion state, our eligibility standards across our different categories are fairly strict when it comes to the financial elements, but you essentially have to meet two components. One are the financial eligibility requirements, basically in any one of these categories, but then the categorical component, which we went over a few of those broad categories in your Casper meeting. So low-income children, very low-income seniors, so essentially your dual Medicare, Medicaid population, very low-income family caretakers. That's at around 45% of the poverty level, and you care for a disabled child, for example. We have a supplemental security income population in Medicaid. We have our long-term care population, both for seniors and physically disabled, in terms of nursing home coverage, and as we talked about already, our home and community-based waivers for long-term care and for the developmental disability population. Pregnant women is kind of rounds out our other categories, and a very small component of what we call other. Breast and cervical cancer populations, employed individuals with disabilities. There's a few very minor groups that very low enrollment, under 500 people. But the bulk of our enrollment in Medicaid and the bulk of folks who enroll and seek eligibility are children. So between our Medicaid kids and our Children's Health Insurance Program, or CHIP kids, that accounts for about 40,000 of our 66,000 currently enrolled members. So almost 2/3 of our Medicaid population are kids. Mr. Chairman, as we mentioned before, just give you a few of the financial elements that we screen for eligibility. So with children, including CHIP, we're looking for family income below 200% of the poverty level. For Medicaid kids, that's 0 to 138%. And then for CHIP kids, up to 200% of the poverty level. For our pregnant women category, that financial limit is 154% of the poverty level. For low-income caretakers, our family care adults that I mentioned previously, around effectively 41% of the federal poverty level is the income standard. For our SSI group, it equates to about 75% of the federal poverty level. And for nursing home and waivers, kind of have a 300% SSI standard there. But as we've talked about before, on long-term care eligibility, we look at assets that are actively held of less than $2,000, which really screens quite a few people out. But Mr. Chairman, just wanted to make a few brief introductory comments about the population we're talking about. Remind the committee that we're not just looking for financial eligibility, although that's a big part of what we have to assess, but also categorical eligibility. And in some cases, like long-term care, DD, that can be very clinical. So both financial and clinical eligibility standards. With that, Mr. Chairman, I'll hand it over to Mr. Springer, give a very brief overview of kind of the application process, what that looks like on our end in terms of screening for those elements, both internal to the Department of Health and externally with our vendors like the Customer Service Center. Talk a little bit about our what we call PERM, payment error rate measurement and eligibility errors, and some changes that have happened from the Big Beautiful Bill recently. And then we'll kick it over to a little bit more detailed presentation about the program integrity unit and all that entails. Mr. Chairman, if that's okay, I'll hand it over to Mr. Springer.
Absolutely, proceed.
Chairman Pendergraph, thank you for having us again. I'm Jesse Springer. So main thing we have is we have everybody who is enrolled with Medicaid has to apply. So they either apply online, by paper, they might fax an application to us. So there's various ways they can apply. But once we get a complete application, we'll screen that application to make sure it's complete, that it's full. If it's not, we'll send requests for information to everybody who's applied. And the core of it, if you're one of those groups that's based only on income, which is children, family care adults, pregnant women, we're going to check the residency to make sure that they're a Wyoming resident. The income against whatever they've self-declared, but also we have data matches with the Department of Labor. We are making sure they're legally residing. We have Homeland Security data matches. We also have, which we use for citizenship and also to verify various work visas. We have data matches with the Social Security Administration, IRS for some things, the Wyoming Vital Statistics for birth and death. So we're checking birth certificates and death records for various individuals, and we do close individuals when we identify that they've passed away. So normally that's communicated quite timely to the Social Security Administration, but we use all the sources of death that we are aware of to identify if someone has passed away. And so we use all that, and then someone still has to be a member of a qualifying group. And so when we say that, that means that they're either a child, a foster care child. So foster care children, we actually treat all of them as income of 0 when they enter foster care. Pregnant women, and then family care adults. So those groups, and there's some smaller groups like breast and cervical cancer, employed individuals with disabilities. SSI, we actually don't screen their income. We receive those from the Social Security Administration directly through an interface. So no one can come and say, well, I'm on SSI, put me on Medicaid. We actually have a trusted interface that comes to us directly from the Social Security Administration that tells us exactly who is on SSI in Wyoming. And if they move to Wyoming, they have to update that with the Social Security Administration. They can't, there's nothing we can do about it unless they've actually updated their records with the Social Security Administration. We can't say, okay, you've moved, we'll start your benefits and you can go figure that out. They have to actually go make those changes with the Social Security Administration. So all those groups can enroll just off income. And in some cases, for foster care, we're not, the children don't have income, at least by our standards. Beyond that, if you're applying for basically more expensive care, long-term care, so that's nursing home care, hospice, intermediate care facility, which is Wyoming Life Resource Center, or one of our home NICU-based waivers, which includes the comprehensive, the supports, community choices waiver, and the children's mental health waiver. For all of those programs, we check assets and resources. And so, we use those terms, resources and assets, but basically those are cash assets plus the value of a home, primary residence, a single vehicle, and some other things. Chairman Pendergraft.
Yeah, you say you check assets. How is that done? For example, say somebody has $2 million in the bank somewhere. How do you know whether they do or not? Is there any data? How does that work?
Chairman Pendergraft, it's first self-declared. So they tell us what they have, and they have to produce the actual records. They have to produce bank statements that are time dated. They need to produce other various things for different types of assets. Insurance. So certain insurance policies have cash value. So all of those are treated as assets and resources. And we do use a service. It's a data service we subscribe to that covers most banks in Wyoming that then also tells us what other accounts may have been found nationally with that same individual's information. So we're checking what's self-declared against what we find through other assets. And those are right now limited to banks, but we are looking at expanding that. Those services have expanded to include property, vehicles, other things. So we are able to identify if individuals have multiple registered vehicles. They can have one vehicle, and under federal law, there's no limitation on the value of that vehicle, that single vehicle, if it's for their own personal use. But we're currently at the lowest standard for home value, which is $730,000. And that's reset annually by the federal government. So there's a minimum and a maximum. The big beautiful bill set a maximum of $1 million. So which, that might be something that Wyoming may want to weigh over time to say, there's a lot of people whose home value has really gone up a lot, but they really don't have very high incomes. And, there's been a lot of effort of the legislature there. So that might be something that's not in statute. There's no guidance to the department on what home value we should be using at this point. So whenever we're absent that guidance, a lot of these have been set to the minimums nationally. So we're using all those type of services to find any resources we are aware of, and then the individual's limited to basically $2,000 cash value. And so if they're a couple, it's $4,000. Cash value plus that home plus the vehicle, and so it's quite limiting. So individuals, even if they have low income, getting below that $2,000 standard can be quite challenging. So a lot of people have to spend down or do different things. And so the $2,000 was set, more than 30 years ago, 40 years ago. So it hasn't been adjusted federally. The states do have the option to change it to a different level, but a lot of people who apply and are really caught up in that $2,000 standard. So once we've screened for all the assets, and we can provide more detail on this, but we're screening for basically all those things, make sure they both meet income standards, which most of the programs that this applies to are on a 300% SSI standard, which is $3,000 a month or something in that range. Plus, they have to meet the resource and asset standards. So once they meet both, and they meet medical necessity for whatever program they're applying for. So if that's community choices waiver, they have to meet nursing home level of care, and that's verified by medical assessments. That program, for instance, has public health nurses go and do those. and they're independent from the client, independent from the facility, and we pay the public health nursing offices to go do the assessments. Once all that's done, and we say, yes, this person medically qualifies, their income is low enough, and their assets are low enough, then they can qualify. For some programs, then they just qualifying is not necessarily sufficient. They then just enter a wait list. So for our support waiver and the comprehensive waiver, well, the individuals could then get onto the support waiver wait list. The other programs don't have wait lists, and that's the functions to get to that point. Other clients, they start services. It's backdated to the first day of the month of application. So once we've finished screening them, individuals are given eligibility back to the first. So if they applied, October 15th, their eligibility will start October 1st. And that's just the standards we use. It's basically eligibility is full month basis. And we work through that. A program we haven't really discussed much is Medicare Savings Program. So Medicare Savings Program has a lot of the same things we've talked about, but has different asset standards and different income standards than we've discussed. But basically, in those programs, we pay individuals premiums or copays for Medicare if they're low income. So that's a benefit that helps a lot of people. They don't have full benefits. They don't have full Medicaid benefits. Their primary health insurer is Medicare. We're just helping on the cost affordability side. Any questions about that before I move on to PERM?
Mr. Chairman. You said that, was it the asset limit, the cash, was it $2,000 and it was set in 1970 something?
Chairman Pendergraft, Senator Larson, yes, it's been a very long time since that asset standard's been adjusted nationally. So we're set at the federal minimum, which has not been adjusted for 30 plus years. Other states have adjusted that, and there has been some requests for information, and I believe even bills in previous legislative sessions to change that asset standard in Wyoming. But we have not changed that. It's only established in state law as a footnote, I believe in 2003, that just asked the department to do that at that time, to use whatever the standard was. But since then, there's been no legislative direction or footnotes. There are no statutes establishing which asset standard we would use as a state.
Mr. Chairman, I've had some people comment on that, obviously. So yeah, I don't know with inflation what the number would be now. Do you know what other states might be?
Chairman Pendergraft, Senator Larson, we have looked at what it would be. It'd be over $10,000 if it had been adjusted for inflation. Some states have a standard of $4,000, $5,000. I think there's a few states that are as high as $7,000 or $8,000. There's one state that has $10,000, I believe, and California was kind of this rare exception where they removed the asset standard completely. I don't think we would recommend doing that because I think they regretted that quite quickly. Their budget got out of control quite quickly to have no asset standard. I think you have to have some level of asset standard for these programs, within reason. And so the asset standard is useful just for saying, what level of assets can a person have, and what have they paid for themselves before the state and the federal government start paying for this care. But to get to the $2,000 level can be challenging because then the individuals essentially have reduced their assets to such a level that, for instance, if they go to a nursing home, it can be very challenging for them to get out because they don't really have assets to leave. So they really at that point may not afford first or last month rent. I know there has been individual bills on this issue in the past, and we've done fiscal notes for those type of things. Chairman Pendergraph, moving
Yeah.
on. Oh,
No,
sorry.
hang on a second. I'm trying to unmute. I forgot I could hit the space bar and then the pop-up screens, and I hate this stuff. What exactly is included in those assets? Is that strictly cash and holdings like that? Or let's say you had grandpa's gun collection, God forbid. What gets included in those assets? Now you're muted, sir.
Chairman Pendergraft, it's a pretty broad definition of assets. So it includes other properties. So there is that allowance for your primary home and adjacent land, that's $730,000. A person can have a primary sole vehicle. If they have a second vehicle, the vehicle has to be valued at its approximate cash value. And then individuals can have a non-revocable, non-refundable burial plot. And there's a lot of legalese in that about the burial plot that it can't be refundable. But then the $2,000 limit includes everything else. It includes ownership of crops and livestock, ownership of other properties outside of the primary residence, safety deposit boxes, vehicles, trailers, campers, farming equipment, all-terrain vehicles, retirement accounts, investment accounts, annuities, stocks, minerals, rights, bonds.
Household goods?
No household goods. So household goods would not be included.
Yeah. Okay, thank
and
you. That
it
helps.
goes and looks at gifts. So it really is a very, very extensive definition of assets, and it's really looking at a lot of resources available to the person, things that you and I might not think of as really like cash, but it is trying to value all those things. So it's a very restrictive definition, which leads a lot of people to not meet it. To your question about guns, firearms, I'm not really sure about that. It's not in our documents. I think we treat most of that as personal effects.
Yeah.
So I don't believe we're getting into people's home items. But I can clarify that after the meeting. I've never heard anyone's gun collection coming up as a reason we haven't given eligibility. So I'm not sure for sure about that, but I don't believe we've ever considered that.
Obviously, I've used guns as an example, but there are a number of people who have collected certain items over their lifetime. Certainly $2,000 won't buy much of anything. I did get lunch at Dairy Queen for less than that, but so
we don't enter anyone's property. So we don't enter anyone's property to verify the value of personal items or anything like that. These are more financial instruments. So a burial plot, for instance, if it's refundable, or a life insurance, whole life insurance have cash value, those are considered to be financial instruments, because essentially they can be cashed out. If the burial does not have cash value, or the whole life cannot be cashed out, usually they'll go out.
So are you able to comment or guesstimate? Let's say that number was changed to $10,000. What effect do you think that would have immediately on numbers of qualifications? Would that cause an avalanche, or would it be relatively insignificant?
Chairman Pendergraph, at $10,000, I don't know that number for sure off the top of my head. We have done scenarios on $4,000 and $5,000. And just remember that it's not changing the income standard. So the individuals still have to meet the income standard, and the income standard is really what's driving most of eligibility. So the asset standard is really delaying eligibility because they are spending down. So the way we've thought about this is it's usually delaying eligibility by a month or two and just causing that kind of burden of getting below that standard, but the people are still eligible.
Okay,
If that makes, or they're going to be eligible, but they're in the process of getting down to that low income or that low asset level. And so other states have found changing just the asset level does not have a major impact, but it would have, our estimate was 100 people would enroll earlier across the long-term care people. And that number could vary based on if it's 4,000, if it's 3,000, 4,000, 5,000, that just starts to have a different effect of how many more months of eligibility we're capturing and how soon. But it's hard to know for sure because maybe there's some people that are not applying currently that might apply if they knew a different asset standard was in effect. But within reason of that number, it likely would not have a major effect. But we could definitely provide more scenarios.
Thank you.
If needed.
Please proceed.
Okay, Chairman Pendergraph. So moving on to PERM. So hopefully that was a good walkthrough of our eligibility process and the groups. I will note that there is a Joint Labor, Health and Social Services has sponsored a committee bill establishing which groups are covered. And they're just, the intent of that bill from the committee was to just denote current eligibility coverage and to denote that in statute so that if those were going to be changed, it would be a legislative action. And it was also noting the screenings that we were saying that screening of citizenship, screening of residency would be required. And we're already required by federal law to do those things. And the committee reflected that. So moving on to PERM. Andrew Chapin, who's on the line, his group oversees the payment error rate monitoring. And so we do a couple things. We internally look at our own performance. And then every 3 years, the federal government also audits us essentially. And they look at 3 major things. What is our payment error on claims? And so in our newest 2024 cycle, our error rate was less than 1%. I'm hopeful when it gets finalized, I think it'll be like 0.5%. So less than 1% there, less than 1% on CHIP. So Medicaid and CHIP are both less than 1%. We don't have a more precise number because they haven't finished the audit cycle. At least at this point, I don't know if the federal shutdown will affect this timeline. We're supposed to receive our final report in November 2025. And once we have our final report, we're happy to share that with the legislature. So that's a great fee-for-service and CHIP error rate. The standard that the federal government is setting is 3%. So we're well below that on our claim error rate. I think this reflects, a lot of investment we've made in our system and just the attention to detail that our staff has if they find an error to go reprocess all the claims that have that error and ensure that those get paid correctly.
Mr. Chairman?
Yes, sir.
Jesse, sorry to interrupt. Would you give the subcommittee a sense of what are we talking about with payment errors that are and the range of what that could be? And Mr. Chairman, the reason I asked for that elaboration is, the public will hear fraud, waste, and abuse, and kind of it's kind of the suggestive term of someone's taking advantage of the system. And yes, that's absolutely part of potential inappropriate payments, but there's also kind of an administrative component to that. So I'd love for Jesse just to give a few examples of what payment errors that the federal government or that we internally would identify, what those could be.
Absolutely, Mr. Springer.
Chairman Pendergraph, so payment error rate monitoring is really looking at, did we follow our own rules in paying the claim? Or did we follow our own rules and the federal rules in making someone eligible? So this is not a review, which we do, and we'll cover, in later part of this session. This review is just saying, are these things done properly? So did we properly pay a claim? Were all the elements of the claim there? Was it properly submitted? Did we follow all of our own rules? Did we pay the claim at the right level and the right rate that we should have? If we require a document, was the document present on a claim? If third-party liability applies to the claim, did we apply it and make sure that the other payer paid? So that's really saying, did we pay everything properly? And I think we could look at this data and just generally from my own experience and say we are paying claims properly, and we don't hear a lot of complaints from providers that we're not paying them properly. And then we look at eligibility, and same idea. Did the people applying for service, did we screen for all the things that we mentioned? Was all the identity documents verified? Did we note that we actually did that? In some cases, in these type of federal reviews, it's that someone might have done it, but they didn't check the box and put a note that they did it. Were all the documents that are required attached to the item? Our biggest error cause in the past has been we do a lot of applications over the phone, and we need to have a phone signature. And our ability during some of these reviews to produce the phone signature was limited. And so, we've taken action to try to make sure that when we get a signature over the phone, which is essentially someone saying, yes, I want to apply, and their voice is there, that we capture that and link it to their application. So that's where, some of this sounds very mundane, but it's basically checking, they're checking to make sure every single element was done correctly. So on our eligibility error rate, for Medicaid, it was 3.64%. So, we're still looking to improve there to get below that 3% federal standard, which was set in OBA. Our kind of concern is, every percentage above 3%, you could be penalized as a state. And then CHIP was 5.19%. And that was complicated primarily by some individuals had retro eligibility applied in error. And at that time, retro eligibility is not applicable to CHIP. What the Big Beautiful Bill of 2025 has done is actually aligned Medicaid and CHIP, so they'll have a lot of the same rules, that have a lot of the same retro eligibility period. So it should help us get our CHIP error rate down. Whenever we have a very small program, which CHIP has 4,500 kids, and Medicaid, which is the much bigger program, having them have very different rules. We're training call takers, we're training application processors. The more they can be alike and streamlined, the better in terms of making sure both are done correctly. So, both of those, we are working with our vendor. So we have a call center vendor that takes the applications and processes the applications. We're also looking at where can we automate things in the Wyoming eligibility system to avoid human error, to flag things that are missing fields or missing verifications, so we can get those things fixed before they come up in an audit. So, this has been a focus area for a very long time, but we're making in my view, good progress improving in here. We just need to make that final push to get below the 3% threshold. Ideally, we'd have a 1% or less threshold. I mean, that's the goal here, is to have zero error. But in the near term, we're trying to get below the threshold. And other states are, I think, a lot more concerned about the 3% threshold than we are. They have much higher error rates. Other cycles have had 7%, 10% error rates in some states. We're not in that range. Chairman Pendergraph, if it's okay, if there's no questions on PERM, I think we could move on to our program integrity area.
I didn't see any questions. Anybody? Everybody happy?
Chairman Pendergraph,
Yes, sir.
I have a question. What were the error rates back 15 years ago when they were doing this in the field offices before it was all centralized here in Cheyenne? Do we have them numbers?
Mr. Springer?
Chairman Pendergraph, I don't have the numbers back all the way to when it was administered by DFS in the field offices. We could provide some trends over the last. So this is done every 3 years. So we could go and try to reconstruct how many cycles we have documentation for. I know we have documentation for at least 2 cycles that we could produce, and we are improving on our eligibility error rate and our claims error rate. So both our claims error rate was the best it's really ever been this last cycle, and our eligibility error rate has been declining. So it would have been 5% for Medicaid, and but the cycle before that had been a bit higher. We will say, if you look at various charts that are around 2013, 2014, you do see a big drop of enrollment around that time period as everyone goes through a new application period and renewal, and goes through the full screening of our new eligibility system and our centralized eligibility staff being in Cheyenne versus in the DFS field offices. There was a very large drop of eligibility and enrollment during that time period, as a lot of people were found to be ineligible, that just through tighter rules. It was a rule-based system versus a human-based system, and just more standardization. It did find a lot of people that were enrolled in that time period that were not eligible after those items were implemented.
Representative Stivar, did you have a follow-up?
No, thank you, Mr. Chairman.
Thank you. Just a kind of a related question, during COVID, my understanding is that disenrollments were frozen. And then after that was over, we began disenrolling. Have we seen any kind of an error rate in maybe disenrolling people that we shouldn't have, or the other way around? Maybe we should be getting a little deeper. What's that looked like?
Chairman Pendergraph, during the public health emergency, we basically suspended a lot of rules. So we had our rules-based system, it was working great, and we had to go adjust it to allow basically violations of our rules during the public health emergency. So, a great example of that is we had 3-year-old newborns. So they were enrolled as a newborn. They're born onto Medicaid to a Medicaid mother. They have 1 year of eligibility. That's the normal standard. And at their first birthday, we rescreen them to see if they're going to continue in the Medicaid child program. During the public health emergency, those children were just rolled forward. And so similar issue with children. We had children and they were just rolled forward. And so we had to turn off a lot of rules in our system. So as we turned those rules back on, we were finding a lot of people that were not eligible. So they were sent renewal notices to see if they qualify for other groups. And a number of people did qualify for other groups. So like the newborn example, a huge portion of those kids did qualify for the Medicaid child group or Kid Care CHIP. So we did see in that rescreening that people moved groups, and especially we saw like our CHIP enrollment really jumped a lot because a lot of families, their incomes had increased. So they actually moved from Medicaid to CHIP. And so that was kind of a natural thing of rescreening. We don't believe we disenrolled anybody that shouldn't have been, and anyone can apply at any time. So if they're disenrolled, they could appeal. So they have appeal rights that they don't believe they should have been disenrolled. They can apply again if they missed that opportunity to appeal. So they could apply again. And they would be rescreened as they're not barred from reapplying. So they could apply every month until they, whatever has changed to make them eligible. For the individuals still enrolled, it took some time to get through rescreening everyone. So there was a tail to this. So from the end of the public health emergency, the federal government gave us a certain amount of time to rescreen everyone. Some states are actually still in the process of unwinding or have just recently completed their unwinding. We were done because our staff really made it a priority and worked a lot of hours and worked very, very hard. We were done relatively quickly, within the first year of that unwinding, and most of that's washed through. A number of people that are found ineligible, especially children, then go on to a continuous eligibility group, which can be 3 months, 6 months, or a year, depending on the type of group, that were required to give some people continuous eligibility under federal law. So that then started washing through the system, but now there's not very many people in that group. So we do believe most of it is all washed through the system at this point, and everybody who's enrolled should be enrolled. We're finding random 1 or 2 per month. How did that happen? Somebody got manually marked for some reason to make it work during the public health emergency, but it's not a common occurrence at this point. So we believe everybody who's enrolled now, we've rescreened them. They are people who are eligible under our permanent rules.
Questions? Any questions, committee? Thank you. Have you anything else, Mr. Spring?
Chairman Pendergraph, we were going to transition to the program integrity discussion. Director Johansson, did you want us to move into that slide deck?
Mr. Chairman, if it's okay with you, we were going to give an overview, now moving really to the more specific fraud, waste, and abuse monitoring, compliance, and enforcement area of the operations. But I want to be clear up front. We sent you a pretty thorough slide deck. We don't have to go through the whole thing, maybe just hit the highlights. Some of that is reference material of, what different examples of types of audits versus investigations are. But if it's okay with you, I can have Mr. Springer and Mr. Chapin just give you the highlights of that presentation, but mostly just wanted to answer any questions you guys have about that function.
Yeah, that would be sufficient. And I think also, there are some people who have been following this committee fairly closely, and they have access to the slide deck, as did we, and I'm sure everybody on the committee has reviewed it already. But please hit the high points for us. Mr. Springer, Mr. Chapin?
Chairman Pendergraph, I'll hit the high notes, and then if I say anything incorrect, we'll have Andrew Chapin jump in. So the main thing is we have our own internal program integrity section, and they work on identifying any payment irregularities. And so they are auditing, doing data mining, using we're now on our second new technology system that does a lot of modeling, looks for fraud schemes, looks for abuse schemes. And so if we find anything concerning, they begin the investigation. If it's waste and abuse, which means like overutilization, then they'll handle that themselves and do various things with the providers, which might include a self-audit, which we could just send a letter and say, we believe you should audit your own claims and make sure you've done this properly. So we've done that for certain hospitals to say, We don't believe this was intentional, but we do think you should audit yourself and adjust claims. In other cases, they'll start a full investigation and come up with these claims. Please produce documentation for what services have occurred. And then if they believe it's fraud, that it's a crime has occurred, they'll make a referral to the Medicaid Fraud Control Unit in the Attorney General's office. And that group will pursue prosecution or negotiated settlement with those if they believe that, if they take the case, research it, do their investigation, and agree that fraud has occurred. There's also various federal agencies that are working on the same purpose. So there's the HHS OIG, Office of Inspector General, FBI in some cases is involved. So there's a variety of federal agencies that are doing audits, data mining. In some cases, they're doing a multi-state investigation, that it's a large fraud ring, and it may involve usually a very small number of providers in Wyoming. Somehow we're not in the fraud ring circle. But those are the kind of major players here. And once we identify these things, we have a certain amount of time to return the money to the federal government. We return their share. Usually it's 50%, but in some cases it's less or more, just depending on how the claim was originally paid. And then we pursue recovery of those dollars. In some of these investigations, the provider is barred from Medicaid and Medicare participation permanently or for a certain amount of time. So they're added to a list. And then we would not allow them to enroll until either that is resolved legally or in some cases until the full debt is repaid. So those are kind of the major items. We also have an eligibility review unit, which is tied in with our PERM sort of efforts. So our eligibility review unit is a group of people that is actually checking the work of our eligibility determination group to make sure, were these determinations done correctly? Was the process followed? And they're essentially self-auditing our own internal group and trying to find errors before they're found externally, so we can either change a process, provide retraining, fix the data. So that's a really effective function. We've been really happy with how that's working. Recently, we've taken over member fraud investigations from the Department of Family Services. That was done in 2022. So that's the eligibility integrity unit, or I always know this as the price unit, but the participant responsibility integrity unit. But we've taken on the Medicaid fraud from DFS. It just seemed to fit better within our own internal Medicaid function. But we do make referrals to each other. So if they find something, they make a referral to us. If we find something, we make a referral to them to make sure that we're aware of, there's an individual who might have been doing SNAP fraud. They let us know. If we find Medicaid issues with a member, then we'll send that over to them as well, just to make sure that everyone's looking at these as closely as possible.
You mentioned data mining, and I know technology is advancing at a rapid pace in a number of different ways. Would either of you be able to comment on how that might be changing? Are we seeing improvements in being able to more quickly identify issues, or what's happening there?
Chairman Pendergraph, we recently installed a new system this year, and it's called our Fraud, Waste, and Abuse Case Management and Detection System. It's with a company called Olivia Analytics, and I'll let Andrew Chapin talk to this, but as part of that project, it really ramps up our data mining, data models. These companies come to the table with essentially packages of schemes that have been seen in other states. So as they build out these core functionality, it's not that we're just doing it ourselves. We're buying that, this scheme has happened nationally. This scheme has happened in one of their other customer states. They also have a big commercial book of business of commercial customers. So if they're seeing a commercial scheme, we can see, is that also happening in Medicaid now? So it's very helpful. Andrew, do you want to elaborate a little bit more on your new system?
Please, sir.
Sure, Mr. Chairman, committee members, thank you, Jesse. So the fraud, waste, and abuse solution is a very unique tool. And in terms of enhancing our abilities to do data mining, it streamlines, as Jesse said, our ability to identify those schemes. And so when historically you'd have an individual who has an idea and then they run and they build a query within our database, and it takes the person in order to generate that, that idea to data mine. Well, now we have, with our fraud, waste, and abuse system, a library of about 100 different models that the user can select from, which then gives you a kind of a ranking order of providers and their practices. And it really just supports our ability to more efficiently identify who are the outliers and who should we be looking at. And so.
Thank you. Questions, committee? Come on. All right.
Mr. Chairman, if I may.
Yes, sir. Yes.
So maybe just kind of, and again, we're happy to answer as many questions as you guys have. There's a lot more information in the slide deck, but to kind of cap off what Jesse and Andrew were mentioning, there's a range of functions we like to have when it comes to program integrity, fraud, waste, and abuse, and sort of administrative controls on inappropriate payments or eligibility. On the payment side and with our interactions with providers, it's one thing to have the tools to identify, potential fraud or potential overpayment or inappropriate payment, and it's great that we have those, and we've advanced a lot in having those. But also on the front end, which I know Andrew would tell you as well, we've had him at HealthStat numerous times over the past couple of years, so he's a HealthStat veteran by now. We also want to make sure that our kind of standing policy is not always after the fact and sometimes a gotcha on the providers. We want to have processes up front that help providers understand the rules. That's where payment policies and regulatory policies like prior authorization, reauthorization, documentation, et cetera, are an important part of limiting the growth over time of inappropriate payments, because you can have situations where if you didn't have front end monitoring and guidance, then a provider who is not intending to be fraudulent at all, but spends years inappropriately submitting claims, and those claims get paid, that can then be a very significant recovery and financial devastation for a provider that had no intent of defrauding the state or federal government, but was doing things incorrectly, was delivering services incorrectly or being paid incorrectly. So it really is kind of a holistic scheme of trying to have, yes, back-end monitoring and relationships with the federal government and the Medicaid Fraud Control Unit and things where there are fraud schemes out there that you want to be able to identify, but especially being able to prevent, the beginning of inappropriate payment or overpayment is something that's kind of baked into the core of philosophy of why we have those, payment policies and regulations on providers. So I hope that makes sense, Mr. Chairman. It's like I said, we put a lot more detail in the slide deck, both on the eligibility side and the payment side, and I think Andrew and his team do a really good job, not only managing and using the new systems and tools we have, but also educating our own staff and our providers on the reason why we're doing these things, and try to be a little bit more front end and preventive in those ways. But like I said, Mr. Chairman, we're happy to go into any additional detail or answer additional questions you all have.
Anything from the committee?
Chairman,
Yes, go ahead, sir.
the question I have is, with my background and knowing a little more, being on labor health, I remember a meeting back in Evanston where you guys showed them graphs of a couple of the people that weren't upfront and honest. And it was a gradual up from everybody else. Are you guys still monitoring that instead of waiting for a year and then hammering them or going after them? As soon as you get an irregularity, are you going right in and looking for the fraud? Because it could just have been a, oops, I misnumbered something, and that's my question. Thank you.
Director?
Mr. Chairman, Representative Stivar, it's a good question, and in general, yes. And I appreciate you remembering those presentations. Not everybody remembers our presentations, so it's nice that you've been around long enough to do that. But yes, so part of what we're talking about in observing the data mining, et cetera, is you can start to identify almost pre-trends when you see, a significant amount of claims from one provider in one particular service or area really outpacing their peers, or growing exponentially over a short period of time, which would trigger Andrew's group and the department to look into that. So the general answer to your question is yes. And I think a lot of these tools we're talking about today, with how we've modernized technology, certainly help us do that even better. So it's not as much of a time lag from when we might start to take action. But yeah, that's I think just looking at trends in the data can help you point the flashlight in the right direction, and these tools with the advancement of technology absolutely help us do that. But Jesse and Andrew, anything you want to elaborate on, please do.
Chairman Pendergraft, Representative Stivar, the main thing we do is that Andrew's group, the program integrity section, actually makes recommendations for program controls and program improvement to other parts. So, one thing they do is this investigative recovery function, but another thing they do, which I think is probably the more important and goes to the core of the question, is to make sure the locks and on the door and the windows are good. Do we have a security system? Do we know who's coming and going? If it starts to be irregular, do we know why? And so, what we have in other areas, we have our provider enrollment function. It has a lot of the screening functions that we have on members. We're checking licensure, death databases, FBI lists. So there's a ton of verifications of the individuals that are applying to be Medicaid providers. And we also have data matching every single month to screen all those people to say, have they shown up on any list that makes them now high risk? In some cases, that triggers fingerprint-based background checks on some providers. Then they're in, and we're watching claims. In some cases, we put providers on review, which means we check each of their claims as they come in, or the service itself has been, had more limits developed, or triggers that when prior authorization or full medical review or plan of care review occurs. So there's a lot of kind of steps there. So what this group is doing is really helping us strengthen those front end controls. And there's also other work groups that are charged with that as well. And trying to make sure that, we're not letting the thing leave as soon as we could stop. So make sure we're not paying for things we shouldn't have paid for. And as soon as we can realize that something's happening, that we can slow it down or stop it. So we're not having these huge recoveries on the back end. And in some cases, it really is just a provider training issue. So, I don't want to say that there's just, most providers are trying to do a good job. There might be a miscommunication between the actual physician or the nurse practitioner and the billing person. There might be a record keeping issue. So, there's a lot of times it's not malicious, but, we still consider it to be an error. So just depending on how egregious it is, I think it depends on what action we take. Is it retraining? Is it a self-audit, or does it go as far as a criminal referral?
Representative Stivar, did you have a follow-up?
No, I'm good. Thank you, Mr. Chairman.
Thank you. Again, thank you for being here. I appreciate your experience, and any comments or questions that you might have, my phone is always available. What are we missing, Director?
Mr. Chairman, that concludes our comments and presentation on the application screening, eligibility, and program integrity functions. But again, happy to answer any questions, or we can save you some time and move on to the next sections of the agenda.
Well, let's just check and make sure that there's no public comment. Do we have anybody standing by for public comment?
Mr. Chairman, there is no one here in the Capitol and no one online at the moment that I can see.
And what are we doing here? I'm glad that you're able to get back into the Capitol. That last week was a little nerve-wracking. At any rate, seeing no public comment, yes, let's move on. I'm going to ask my committee, check your text message. I'm trying to resolve a couple of things here before we get to the committee directives. And in the meantime, Director Johansson, I see that we're in line for some federal updates. Please proceed.
Mr. Chairman, thank you. So the big item that we had discussed at our last meeting, and we're close to completion on it, is the results of the One Big Beautiful Bill Act, or HR 1, and specifically the creation by the federal government and the administration of the Rural Health Transformation Program. Unfortunately, timing is always an issue, so the application is not due until next Wednesday. And we have basically a draft finalized that the governor will be reviewing this week. But just to give you kind of the same updates that we gave the Labor Health and Committee at their recent meeting, is that in order to develop the application for the Rural Health Transformation Fund, which, if I back up, is something that was created by the Big Beautiful Bill Act. Congress appropriated $50 billion for this program dedicated to improving rural health. And there's two tranches of funding that states are eligible to potentially be awarded. One is distributed kind of on an equitable basis based on population factors and things of that nature. And the second half is really based on kind of a competitive application and scoring by CMS, the federal government, of that application based on the initiatives you select, what you've prioritized, et cetera. And again, as I mentioned, it's been a very compressed timeline. That application guidance from the federal government came out in mid-September with a November 5th deadline for application. During the remaining weeks of September and into October, we prioritized public engagement in terms of developing this application. So we held 11 town hall style meetings in person in rural communities, as well as a handful of virtual town hall style meetings for those who weren't able to attend in person. Probably won't hit the whole list right now, but if memory serves, we went to Wheatland, Newcastle, Buffalo, Laramie, Riverton, Lander, Powell, Evanston. We hit as many communities in a short timeline as we could, and again hosted town hall style meetings to get a sense of what's working really well, but also what are the priorities and we tried to structure it in a way that didn't generate a wish list of items to essentially pay for, because there's a lot of strict guidance from the federal government on what will be allowable and what won't be allowable. For example, just increasing reimbursement rates in Medicaid, for example, is not allowable. Building new healthcare facilities is not allowable. But so we tried to structure the town hall in-person meetings as a way to kind of put people in the same boat that we were in having to prioritize things. And as I told the Labor Health Committee, I think this subcommittee and the legislature in general should be very proud of your constituents and your communities in Wyoming, because we did not get a wish list. What we really got was consistent feedback around the basics. And we we took those town hall meetings and the feedback we received from the public and the attendees of those meetings to generate an online survey where I think we got at the end of the day 13 or 1400 responses, so a really pretty good response rate. And we were able to use what we heard in the town hall meetings to then do an online survey and have people kind of in a forced environment have to rank order and choose between, make tough choices. And we were able to quantify some of that feedback into kind of our top 10 areas that we heard from the public. And a lot of those were quite simple, which again, I think it's something that was indicative of the culture in Wyoming and how people think about, if I was going to move or live in a rural town, in a small town, what's the most important element of healthcare that we feel like we need or we need to keep sustaining? And it was things like the financial viability of our small rural hospital, an emergency department that's available, an ambulance that shows up when you call 911 in a reasonable amount of time. Some decent access to primary care, primary care provider, and behavioral health provider potentially being integrated. So those types of things really have informed our development of this application, which we hope to submit to CMS, to the federal government next week. Mr. Chairman and members of the committee, we're not sure if the federal shutdown will impact timelines here in terms of review and approval or award. But we do know that per the Big Beautiful Bill Act, CMS and the federal government should have award decisions, at least in general terms, by the end of the calendar year, so by the end of December. It's possible that through negotiations on our application with CMS that we could see that bleed into the early part of 2026 in terms of the back and forth of what we may or may not be approved for. But we do see this as an opportunity with a lot of upside, not because the Department of Health is scrambling just to get its hands on more money, but because what the Big Beautiful Bill Act did and some of its other changes to Medicaid programs and health departments is not something Wyoming is going to see. And what I mean by that is you have other states and other Medicaid programs that are seeing quite a bit of federal funds be removed from their Medicaid programs or their health departments because of various provisions of the bill. So things like federal match rates reducing for various reasons in Medicaid expansion states, or these programs we call provider tax or supplemental payment programs that Wyoming has not abused, but we do have them. We've always been under the federal thresholds and the caps. Other states were maybe not in the same position, so they're seeing potential major funding reductions in those areas. And again, Wyoming is very different in that regard, in that this program for rural health transformation that the administration prioritized and that Congress passed gives Wyoming a lot of upside to potentially solve for some very difficult challenges in Wyoming, like the financial viability of our small hospitals, the availability, regionally and reasonably of obstetrics and labor and delivery care, again, connected to hospitals, the viability of our rural and frontier emergency medical system or EMS services, and a few other items that we're designing into the application. But wanted to provide that update, Mr. Chairman, and also use the opportunity publicly to thank the members of the public that engaged with us, thank the provider community that engaged with us, and really, I think it was a unique experience. And like I said, it would have been very easy for us to just say, okay, we have a list of 500 things. Let's take, $100 million per year and divide it up. But instead, what we heard kind of in a resounding way was, if we had to prioritize, it's really these, 3, 4, 5, or 6 or 7 things that are very important to our town or our region or our county. And so I'm optimistic that we'll present a really good product, which obviously we're happy to make public when it's final and submitted for the federal government's consideration. Mr. Chairman, since this subcommittee is made up of all appropriators, you had asked me last time, how would that influence, the Department of Health's budget? And we're still a little bit early in that game, but there were several budget requests, as you'll recall, last year, for example, that were related to OB care, right? Medicaid reimbursement rates for OB care because we've had several hospitals either curtail or close those services altogether. We have, as we discussed last time, we will have those discussions again since the budget failed last session. You had asked me which budget requests are likely to come back. That's probably one of them, but with some asterisks on them because we just don't know at this time how that will interact with a potential federal award that could really change the dynamic of what the legislature needs to appropriate or we're asking them to appropriate. So that could look a couple of different ways. For example, maybe budget office and governor recommend one-time funding while we see how that program plays out. Or deny it altogether. Time will tell as the governor puts his budget together. But I do think basic conclusion from my end is that we had really good public and provider engagement in this process in a very well-funded program that had a very compressed timeline in terms of its development. So can't stress enough the gratitude that we had as a department. And I won't speak for Governor Gordon, but his office was heavily involved in helping us, stand up a lot of those public meetings and be engaged in that way. And so I think he would echo the same sentiment that we really did hear a lot of great feedback and challenging feedback from the public about what we should and what we should not prioritize. And I hope that ultimately is reflected in our application, which we hope to submit next week. With that, Mr. Chairman, I'll stop and see if there's any questions. That's probably the major federal update outside of the current shutdown, which I'm happy to address any health department interactions there as well.
Committee questions? All right, we're kind of at that unique spot where we're all waiting on a few things. I think Thursday we're supposed to get, the appropriations is supposed to get an update on the Craig report. That will tell us something about where we stand, and that will be helpful. Before I get to that, by any chance, is there any public comment, any further questions from anyone?
Mr. Chairman, there is no public comment at this time.
Thank you. We can't say we didn't give them a chance. And my plan is to give them one more chance. We have another meeting scheduled on the 7th of November, and that will be a live one in Casper so that anybody around the state that wants to come and speak to us would have that opportunity. That's the primary reason that I want to have that last one, is to make sure that the public is given every opportunity to come in and weigh in or to ask questions and see what's happening. Also, by that time, some of these questions, the governor should have looked at your application. We should have a little better sense of that. We should have another Craig report under our belts and maybe have a little bit more information there. Also, between now and then, and I would say probably within the next 24-hour questions, or within the next 24 hours, our committee is going to meet privately and kind of discuss where we're at. And are there any things that we've gone over in the last 3 meetings that we would like to approach again? I know I have a few questions left on the stat, and just kind of give us one last shot on that morning, and that public meeting should be finished probably by noon, if not before. And then with all of us in Casper, we'd have an opportunity to talk a little bit about where we're going. So any questions on that or comments? All right, Miss Martineau, I will be getting with you within a day or so to give you definites of where we're at on that. But I think the plan going forward is fairly straightforward. Am I leaving anything out? Would LSO perhaps give us a brief review of where we went today?
Mr. Chairman, today you discussed a little bit about the workforce challenges that the Department of Health is encountering and some of the updates and kind of actions they've been trying to take to alleviate those problems, including working with the Department of Administration and Information Human Resources Division. There was some teasing, as I'll call it, of a potential exception request. So there is some information that will be forthcoming from the Department of Administration and Information as well as the Department of Health regarding kind of what those cost savings might look like going to the 2024 MPP versus using those traveling nurses or contract services. You delved quite a bit into the health stat and that project and looking at some of those details. If you do have any questions on any of those areas, I'm sure the Department of Health as well as myself will be willing to do any other additional research you may have there. And then finally, you had an overview about Wyoming Medicaid, and you talked a lot about what some of those services are in terms of keeping fraud, waste, and abuse at bay. The presentation, I would note for the public, is incredibly in-depth. And so if you are curious about the specific mechanisms that the Department of Health uses, including some of those definitions, I would really urge you to go and look at that presentation. The department did an excellent job of providing an overview, but they do define quite a few of those more commonly used terms and how they're combating those items. I heard from you, Mr. Chairman, that for the November 7th meeting, I will be working with the chairman to get that agenda out as soon as possible. It looks like it will be a half day in Casper. Public comment will be the focus in the morning, as well as any additional final items that a subcommittee or the Department of Health may have. With your permission, Mr. Chairman, we might also put that final federal update on there as well, so you can hear about the application and how that went.
Yeah, that was my intention. Director Johnson.
Thank you, Mr. Chairman. Something I neglected to mention after our first topic this morning on the Department of Health workforce. My friends at A&I did message me based on a question I believe Senator Larson asked of what the typical or average benefit load is on state salaries. That's a 26.55% benefit load when you talk about retirement and health insurance for the average employee. So I neglected to mention that after we had moved on to other topics, but wanted to make sure that that was on the record.
Thank you for cleaning that up for us. Senator Larson, any follow-up on that? Okay. All right. Anything else that we've left untouched? Speak now or forever hold your peace. All right. I again want to thank the LSO staff for their fine work, and you guys do a great job. Director Johansson, Mr. Springer, thank you guys for being here and being patient with us. We may want to talk to a couple of the program directors out of the Department of Health, but we'll certainly get that to you so that we can be available. And I look forward to interesting discussions on where we go from here. So thank you for being here. And if there's nothing else, this meeting is adjourned.
Thank you, Mr. Chairman.
Thank you.